And what I actually said to OTs, said to the students, or second year students, is that when you go in to do an assessment in someone's home, the privacy of someone's home, just never forget that you've been invited into their home.
But ultimately, like you, correct me if I'm wrong, like you presented a business case that ultimately saved the trust a lot of money and probably continues to do that.
At the minute, they are all out in the field and they're all playing, but nobody's keeping score. I mean, that's a wee bit like the health service.
Yeah.
You know, everybody's doing their job, but who's keeping score? So we're back in the Martina Tierney Podcast room, and I'm delighted to be joined by two very handsome men across the table.
First time I've been called that, Martina, but thanks.
With their grey hair.
Anyway,
so we have Shane Elliott, and Shane is the Housing and Health Lead for Northern Ireland. You're very welcome, Shane.
Thank you,
And originally an occupational therapist. So I'm going to come back to that in a minute because I need to introduce Dean Cooke. And Dean is our global product manager here at Seating Matters. And he's your biggest fan, and that's why we have him here.
There's a mutual respect there.
Because Dean just thinks Shane can do no wrong. And I would agree with him. Shane is the man. So we'll go into both of you in a wee bit of your background, and then we'll just keep going there. So tell us, Shane, about yourself. You're an OT by background, and tell us a little bit about how you started and where you come to, where you are today.
Oh, God. Well, thanks for having me, first of all, Martina. I'm an OT now, 33 years, just over. Qualified.
And do you still consider yourself an OT?
Oh, I still consider myself an OT.
Okay.
Would still be very involved in the OT world.
Good.
Would still have a lot of work and projects that we're involved in that would involve OT. I did still describe myself as an OT. But I qualified in 92, so a long time ago now. I suppose sometimes people ask me, why OT? How did you get into the profession?
Yes.
And do you know what? I don't know. I fell into it by accident probably as much as anything else, which people find hard to believe now. But because when you're 18, I was so immature. You're making decisions about your future. I hadn't a clue.
Yeah.
I was going to be a quantity surveyor. I was going to work in a bank. I was going to work in construction. I was going to do all sorts of things. And OT just happened to be one of the things I applied for and got in. So I started my work career, a very brief synopsis. My first job was in Belfast City Hospital in 92. If you remember a lady called Anne McCall.
I do indeed.
Who was the head of service at that time, who was in many ways ahead of her time. I was there for about 3.5 years and learned an awful lot in terms of, because she was very driven by standards, Anne McCall, and it still stands to this day, actually. So then I always wanted to work in community services, and I always had an aspiration to work in housing, because it was always the space, because like everybody else in OT, everybody will say we come into the job to make a difference. And I could tangibly see the difference that good, accessible housing made to people and the difference it made to their life. So it was always the area I wanted to end up in, which is why I'm in the dream job now that I'm in. But I then went through community services, worked for a number of years as a clinician, worked as a community head of service, worked as a clinical specialist in housing for a number of years, and then was head of occupational therapy service for the Northern Trust for about 7 years before I then moved into this job.
That's the Northern Trust here in Northern Ireland.
The Northern Trust here, yeah.
This podcast goes out across the world, so we just need to make sure that people know where you are.
Well, that's the Northern Trust in Northern Ireland, one of 5 trusts in Northern Ireland. So I was head of professional services there and also managed equipment services as part of that job for 7 years, and then was seconded into the job that I'm in now.
And Dean, that's where you would have got to know Shane, was the equipment service. When you were head of equipment services, did you
Not
say?
at that time.
When I took on the head of OT services, the head of equipment services came with it. It came with it, which was a job in itself. Yeah. But massive learnings from that. But I would have known Dean as a clinician, as a manager. I would have managed the budgets. I would say Dean bought his first car after what I bought off him at the time. So I would have worked closely with Dean as a clinician and a manager. Yeah. So massive respect for his, and he's great standing in the OT world, there's no doubt.
So Dean, tell us a little bit, just to introduce you to the podcast, because this is the first time, but not the last, that you're going to be on the Martina Tierney podcast.
You did peer pressure me into this only 10 minutes ago. So,
so when you met Shane while you were working in the community?
That's right. Yep. So I suppose going way back, Martina, I started with you maybe 20 years ago.
Yes.
as like nearly like a service engineer, and followed you around the country, taking the chairs and watching you do assessments, and sort of sitting back in the corner and soaking it all up. And I always say to folk that I was nearly like your wee Seaton apprentice. I learned so much.
My fourth son.
Yes, I've been referred to that many a time. But I just learned so much in that year from watching you and Sharon and Kathleen do assessments. It was just seeing the impact that Seaton could have. Like, you would have thought, you know, I did not have a clue. I'd never been in a nursing home in my life until I started with you. So just to get the scale of the problem and see how Seaton was impacting people's lives, it was really unbelievable. And then you sort of forced me into doing assessments. Again, peer pressured into that too. And and here I am. So started...
and that's where you came across Shane.
That's where I came across Shane. That's right.
The relationship with Shane developed when you worked in the community.
That's right, yeah.
What did you find? What was the link? What did you find about Shane that really resonated with you?
That's a question. Shane was just... he's just like... You ask every occupational therapist in Northern Ireland will know Shane. And if you ask any of them about him, they all have an unbelievable word to say about him. He's compassionate. He's very empathetic towards his patients. He's very, especially when he became a manager, there's a lot of services he put in place that was actually quite groundbreaking. Like the modular ramp, which I do want to talk about, Shane.
Love to talk about it. Yeah.
I mean, do you want to maybe talk a bit about that, or?
No, I was enjoying you talking the way you were talking, so, Dean. I was going to let you carry on.
Do you mind if I just tell the story, Martina?
Absolutely, tell us about the modular, because it made a big difference.
It made a massive difference, and at the time, it didn't. You know, at the time, you don't think about it that way. But knowing that Shane was coming on and thinking and looking back, the impact that had on service users in the Northern Trust was just phenomenal. So, like at the time, if anyone needed a level access ramp to their house, they had to go through the disability facility grant process, which is a timely process. It could take a year and a half, but the government will essentially fund, in a lot of cases, like a concrete ramp for people. And what Shane done was he introduced a system for the modular ramps, which is like an aluminium structure. It's like a big jigsaw. You can come and build it in an hour and have someone can get immediate level access ramp. And it's a much more costly version. It's maybe 2-3 times the cost of a concrete ramp, but over the cost of the lifespan of the equipment, because you can reuse it in 10, 15, maybe 20 different properties, it cut the cost way down. It actually made it much more feasible to do that. But it took someone, I suppose, with the foresight that Shane had to be able to present that case to the trust and say, this is going to be a huge investment. It's going to cost a lot of money, but in the long term, it will pay dividends. And on the human side of that, it gave access to people whether it was palliative care, whether it was dialysis, chemotherapy, maybe people that needed rehabilitation, day centre access, they could get a ramp in a day. In a couple, if Shane clicked his fingers, the ramp was in the next day. And I just think that level of service to some of the most vulnerable people in the community was just unreal. And Shane's trust was the only trust to do that initially, and then with your influence on the housing group, Shane, it sort of slowly spread across Northern Ireland.
Yeah. And is that standard across Northern Ireland now, Shane?
It's not, although there've been moves in that direction, but I still, and it's very kind of you to say what you did, Dean, I still am banging the drum around modular ramps, particularly within the housing executive, because we applied it to private sector housing. We're really now trying to, and the housing executive now have agreed to a pilot in terms of, so we have made inroads that it's going to broaden beyond the Northern Trust. Some trusts dip their toe in it. The Northern Trust is probably the only one that has a contract and a procurement process in place. And what drove me to look at that is, because I'm blown away by your culture here, by the way, and your lean made simple. And the modular ramp was a classic example of trying to make something a bit leaner, because people who had access issues, who couldn't get in and out of the house, were having to wait 6 months, a year, 18 months sometimes, to get a ramp that would enable them to do that. So if you're at the end of life, or if you have a rapidly progressing condition like a motor neurone disease or whatever condition that might be, these can be installed next day.
And they're reusable.
And they're recyclable. So it was even looking again, and within the health service sometimes it's all very fixated on your your expenditure for that financial year.
So frustrating.
Everything is driven by what money you have for that year. Whereas we could see, and I could see from an early stage, that the benefits of this could potentially take 5 to 10 years in terms of building up the stock so that you're recycling stock, so you weren't having to buy stock because you had enough because you were taking it in and moving it out of the properties. So I'm a massive advocate, still am, still people get fed up hearing me talking about them, but it's just an example of how we can do things much leaner than what the current systems and process, because the people that need it now. They can't get in and out of their house, so they can't wait 6 months, 9 months or whatever it takes.
Well, there's two things I want to say. First of all, that is what we would like to see for seating. That people look long term rather than this, fix it now, worry about 6 months' time. And we've been pushing that a long time as well, but we haven't really got there yet. But we'll keep banging that drum as well. But the other thing that I'm doing a talk at the OT show in a couple of weeks' time, and it's called Yokoten. And it's one of our Japanese phrases, and it's for spreading good ideas and good practice laterally across the team. So by you doing this podcast, like, there could be somebody out there that have never thought of using modular ramps across the UK or across the world, and that is the whole idea, is to spread that message and that of good practice across the team. So hopefully we'll be able to do that as well. So tell us a bit more now, Shane, about your current role with the Department of Health and Housing Executive.
Well, the current, it's probably unique to the jurisdictions. I don't think there's any other Scotland, Wales or Northern Ireland or Southern Ireland for that matter that have a similar post. So it's a bit unique, but I followed on from Pádraig O'Brien, who I know Pádraig
He's been on our podcast.
Pádraig's been on your, and Pádraig's been a great friend and mentor to me over many years. But so the job really means that I'm jointly employed by the Department of Health, and they pay half my wages, each of them. So it's very interesting. You have two different organisations with different cultures, different approaches to things, and so there's a lot of learning in that. But my job primarily is to look at how do housing and health interface. How do we collaborate? How do we work together to find housing solutions for people with disabilities? That's it in a nutshell. It's a wee bit more nuanced than that. But I would also then have to ministerial questions. So I would actually, the minister ultimately would be my boss.
Minister of Health.
The Minister of Health. So I sit in the Chief Nursing Officer alongside the Chief Allied Health Professions Officer would be my boss, with Michelle Tennyson within the department. So if there's assembly questions that would come in related to my work, I would input to those. We would try to identify where there might be policy gaps that we need to provide clarity and guidance on from the departmental perspective. But the major piece is the collaboration piece and looking at how are we working together, how are we being joined up. Because what you see sometimes, people fed up hear me say this in practice, is I call it responsibility tennis, where you have someone trying to find a solution and health are saying, well, you need to go to the housing executive for that, and the housing executive, well, that's a health issue, that's nothing to do with us. So really what we're trying to do is bring people together.
Total ownership.
Total ownership. Everybody wrapped around, everybody that can help to find the solution is in working together, talking to each other, building networks, building relationships. So there's been a huge part of the first 4.5 years of building those partnerships, and we've set a number of partnership forums in place. We now have an interdepartmental strategic forum in place, so we have the right people talking to each other to try and make things happen. Not without its challenges, but
absolutely. And that was my next question, like, what is the most frustrating thing about your job? Because every job has its frustrations.
It certainly, probably what frustrates me most, because I'm quite an impatient individual, is it takes far too long to get things done. And things that I would like to make a decision on, or you have to influence and you have to cajole and you have to bring people with you, and that can be time consuming to get to do that. Because previously I was head of service, and it sounds very egotistical and it's not meant to be, but when I was head of service, at least I made decisions for good or for bad.
You could make your own.
I could make decisions for good or for bad. Sometimes but you had to make decisions. In the job that I'm in now, there's not so much decision making; it's more influence and networking and trying to influence people that this is the right thing to do. And that's just, it takes time. That's the problem. So that frustrates me sometimes.
And because of your personality, because you are someone who likes to get the job done, like you did with the ramps, you saw a problem and you found a solution, but it's a bit slower.
It is.
But we need people like you to stay in there and to keep banging that drum, because we were talking earlier before we sat down, that a lot of people get frustrated in the health service or in the housing executive because they are constricted by rules and regulations, and therefore they leave and they go and do something on their own, which is okay. I've done that, but we don't want all good people to leave. We want them to stay in there and keep moving for change. So
totally. And I admire people like you that have done that, because it's a very brave thing to do, because we sometimes get a bit institutionalized, and sometimes I feel a bit institutionalized. We get sort of the security of our pension holds us in our jobs, and we're a bit risk averse in terms of taking leaps of faith out of the system. But you're right. I think we need to, it's a bit like, sometimes I use the analogy of the Shawshank Redemption. Have you ever watched the film The Shawshank Redemption? One of my favourite films of all time.
Actually, I was telling you earlier, I'm doing this counselling course, and that's all they talked about one night at this course, but I actually have never watched it. It sort of scares me. But I don't like. But anyway, tell me about it.
Well, I'll tell you, because you talked about banging the drum, and sometimes I feel like you sound like you're on, it's just on a never-ending circle of saying the same things. But I think we do need to stay in there and try to work within the systems that we're at and bang the drum. And it's a bit like why the Shawshank Redemption was Andy Refrain. If you remember the whole issue around the library, where he wanted a library in the prison, and he wrote every single day for 2 or 3 years to whoever it was, to eventually they says, give him the library. And things like we talked about, sometimes you just have to keep banging the drum and sending the letters, sending the emails, to eventually somebody listens, because it can take a while to find the right person to make it happen. So you just need to have a bit of a resilience and a bit of stubbornness probably about you, to not let something go that you can see will make a difference.
That's right.
And that's difficult for people because the system is quite bureaucratic. We still work in quite process-driven bureaucratic systems, which for free thinkers like yourself can be extremely challenging to work in. There's no doubt.
That's right. We were also talking earlier, Dean, about what makes a good OT. And you are the expert because you've worked with them. You've worked with them all. And we're trying to pinpoint, like, what is it about, and can you tell us what you said? What do you think makes, you did pinpoint something?
So certain qualities I think that a good OT always has is being compassionate towards a service user, having empathy for the service user, and sometimes just having that decisiveness to make a decision, because it can be tough and sometimes there's a lot of to and fro at times, but a good OT is always decisive, always confident in their abilities and will make decisions.
Yeah. And just something that that you have a bit of a problem with at the minute. You feel that OTs are very risk averse. It's actually somebody mentioned in this book as well. I think one of the contributors said that OTs are risk averse.
Yeah.
Why are they risk averse, and how can we change that?
I think the system's partly to blame. I think our professional culture is partly to blame. I think our how we're managed is partly to blame. I think there's a whole lot of things contributing to that. The fear of making decisions, having to work within confined systems, not allowing people to be autonomous thinkers and decision makers, and being very hierarchical in our structures, all contributes to that risk aversion. I would agree. I think professionally I see a lot of professions. We're certainly in the top 5 professions in terms of how I would classify risk aversion. And I think we need to, going forward, we need to develop a much, much greater appetite for risk and taking risks. Now, I think we need to balance that with, that doesn't mean being reckless. There is a balance to be struck. We shouldn't and should never be reckless in terms of our practice. But there's certainly areas that I can see very easy wins in terms of taking risks and stop. I sometimes make the reference as a profession, we need to stop sweating the small stuff, and we need to focus in on where our skills in postural management and housing and in wheelchairs and even in rehabilitation services, and we really need to focus our skills in on those people who need it most. And there's stuff that we're still doing professionally I don't think requires an occupational therapist to do. So I think we need to broaden our thinking in terms of, because we're still practicing like we practiced 20 years ago. And I've often said to college, I've been quite open about it, that the profession for me needs a reset. I think the whole terminology in the department at the moment is reset. There's a reset plan in place, and I think professionally we should be resetting. And by that I mean take stock of where we're at, think of what needs to change, and then try to work out ways how we can make that happen. Yeah. And the problem is, for me, that the system, again, people are so immersed in the weeds of the day-to-day business they can't even look up to see around them and do make the change and even talk about what changes need to happen, because they're so fixated on moving people through the system. And that's the way we've set up. We've got a very target-driven culture, which is very well, because we don't want people to wait. But I would rather wait 20 weeks and get an excellent service as wait 2 and get a service that is rubbish.
Yeah. That you have to revisit.
That you have to revisit and you have to go back.
Months.
Absolutely. So, and I think the population would see that. And I think there's maybe management of our whole cultural expectations around what they expect from health services. But I just think we've lost our way a wee bit in terms of our practice. And I think at some point we need to sit down and look at where we're at and where we want to go.
Yeah.
But
so I'm just going to take a wee side issue. I'm just going to move it a little bit away, a wee bit from OT, because apart from being an OT, you are involved in sport. Mm-hmm. And I'm sure there's some similarities because you coach, is that right?
I do.
Manage or coach?
Coach and manage. I do both.
Right.
Yeah.
Tell us a little bit about that.
Well, my sport is hurling. I'm from Dunloy.
County Antrim.
I'm from Dunloy in North Antrim, born and bred, and I still live there. I did live in Belfast for a wee while after I qualified, but when I get married, I come back home. So yeah, I've been immersed in hurling. My father was very involved as a manager and a coach, and I've been immersed in hurling since I was 5 years of age. So if I have a passion outside of life, it's hurling. I played at a decent level for quite a number of years, and then I moved into coaching and management. So
your son plays as well.
And my son plays now.
How many family have you?
I have 2. I have a boy and a girl.
And Ryan, is it?
Ryan, yeah, you've done your research.
Well, I was reading about Ryan and his hurling.
So Ryan's 27, Hannah's 23. Both still at home. I don't know, we'll never get rid of them, but they're still at home. So yeah, he's a hurler, goalkeeper like me. I was a goalkeeper, and my son has evolved into that as well. So it's been, it takes up a lot of my time and energy outside, but it's brilliant for your head clearance and
for your mental health.
Absolutely. It's, you talk about, they talk in psychology terms about being in flow. It's when you're on the pitch or where you're coaching, you're in flow, nothing else. If you've had a stressful day at work, it's gone because you're in that moment.
Totally focused
on that. And that's what gives me flow. There's sometimes you could see it far enough, because when you're not successful in all of that, it's time consuming and all that, but the benefits far outweigh the negatives. So as a consequence of that, I am fascinated by cultures of organisations. I'm fascinated by cultures of teams, and both in sports, but also in terms of how businesses operate and function, which is why I've been so impressed by the walk around I had in your factory and your lean made simple approach, which I think there's massive learnings could be had beyond business. I think in health, sometimes the culture is, we still have a very medical model in terms of how the culture it's all the black and whites. We're looking to try and resolve things, and there's an awful lot. I know we were talking before, there's an awful lot, particularly in occupational therapy, of colouring in the grey, and that needs lateral thinking, that needs thinking outside the box. But going back to the sporting side of things, I think there's massive comparisons in terms of culture across both. Yes. So I see things, even with what you've talked to me this morning, that I think, God, you could use that in sport. And I certainly, I would imagine you have also learned through sports in terms of how that can transfer into the business world as well.
Like when we're doing our learnings and that, we use sport a lot, don't we, Dean, as examples of, how a team work together, the work as a team. It's not people off siloed, everybody's working towards one goal. So we use that a lot. So we do. And the other thing just this week, we were doing a meeting at Spur and Metal, and he was doing the meeting on, at the minute, they are all out in the field and they're all playing, but nobody's keeping score.
Yeah.
I mean, that's a wee bit like the health service.
Yeah.
You know, everybody's doing their job, but who's keeping score? You know, how well are we doing here?
Yes.
You know, and that's what his learning, Ryan, my son, that was his learning for the team this week was when you're on the field, it's not just good enough to do your job, do your little bit. You need to be looking at the goals. Yeah. Is there anybody scoring a goal here?
Yeah.
You know,
so
you can learn a lot from sport and business together.
You definitely can. And I can see, I've been involved in teams where I can see where they've malfunctioned on the back of the culture that was embedded in that. I've seen the impact of, use the word, toxic sometimes, where you see individuals who aren't team players and how that can really erode the culture of a team. And you can see how that can happen in business. I can see how it can happen in the workplace. So where you develop healthy cultures, I think you get the best out of your team. Yeah. And obviously I can see that with where you've operated your business. We can see that with what we try to do in our sport, that if the culture's not healthy, then you're not going to perform to your best. And I've seen that many times over many years where the culture hasn't been right, and that has seriously impacted on how the team have performed.
Do you feel in the job you're in at the minute that you can influence a little bit? Do you feel that, because it's like starting small, do you feel you could get like one or two people around you, a team around you that might just start to change the culture a bit?
I think I can. Yeah, I think the position I'm in is probably a good position to do that, because part of what I need to do is try to influence and inform what the future strategic and policy direction within the Department of Health is going to look like. So there's a number of things that we're doing that will have huge impacts, I think. I completed a regional review of assistive technology and equipment services for Northern Ireland recently. And that has developed into now what will be a major project within the department's reset plan. So that'll have huge influence in terms of how OT practices.
Looking at things in a more regional rather than being siloed in their little geographical areas.
Absolutely like that. It's looking at we have a permanent secretary who is massively into the reduction of regional variances and moving towards, with a population of our size, 1.9 million people or whatever it is, that we should be more regional in terms of how we do our business. And that's what I've looked at that from an equipment perspective. So it's about regionalisation, but it's also about reducing clinical variations. So it's trying to be more consistent in terms of how we actually practice. That if OTs or nurses or whatever are practicing like that in Ballycastle, it should be very similar in terms of what the practice looks like in Newry, for instance. And there'll be different. So it's sort of, those are the two main priorities. It's sort of standardising how we do things a bit.
And sorry, Martina, you were like sort of instrumental then in the framework for the postural management framework.
Yes.
The regional postural management framework. Like, weren't you really headlining that, like driving that, how OTs across Northern Ireland are all doing the same thing, following the same paperwork, doing the same assessment, following it right through. That's part of that.
I led that group, actually. I didn't have the clinical skills at that time because I was a bit detached from clinical practice. So, whereas I used to be able to prescribe a chair, I wouldn't trust me to do it now. But yeah, we led that postural management group where we looked at the assessment process, the documentation process, the prescribing process, to try and have and we've done the same in housing, to try and have a regional consistency in terms of how we do things. So yeah, that probably set. And then I managed equipment services in the Northern Trust at one of the 5 trusts. And that really gave me a sense of things need to change and how this is delivered. So when I came into the department, I said, look, I think you should review these services. I think they really need to review, because I think they've massive potential in terms of regional approach, looking at our resources, looking at sharing our resources more widely, and pooling resources even to that point, so that if you need a wheelchair or a specialist seat, if I use your specialist seat, if you need a specialist seat in Ballycastle, you should get it in the same time frame as you get it if you lived in Newry or Strabane. So at the moment that'll be very dependent on the resources that each of the trusts have. So you might get it in 10 weeks in Ballycastle, but you might wait 30 or 40 weeks in Newry. for the same thing.
Yeah.
So that's really what we're trying to do, is having just a much more regional, consistent approach to that sort of thing.
Standardisation.
Yeah. You know, we're only 1.9 million people.
Yeah.
When we look and we benchmark across to places like Glasgow and London, and you know, we're just far too unwieldy in some areas.
So Northern Ireland, like, there is only 1.9 million people, but we do punch above our weight many times. So, like, there are plenty of examples of that.
Absolutely, there is, and we shouldn't be too sure on ourselves, you know. And I don't want to come across negative about how, because our profession is doing so much good stuff, so much good stuff. But we need to recognise that doesn't mean to say that we shouldn't be looking for ways that we can do other stuff. No. And, you know, I'll use the example of the toolkit all the time. We developed an interdepartmental adaptations design toolkit that Porrig would have been involved in, I was very involved in, the housing executive were very involved in, which set standards and regionalised our practice in terms of how we communicate, in terms of our space standards and all of that. And no other jurisdiction that I know of has anything similar to that. And I know from correspondence that we get that people in Australia use it. So it is a wide range. I know it's looked at in Scotland, Wales, Northern Ireland, Southern Ireland. So we have developed some quite innovative stuff at the same time. So it's not all bad.
Have you ever spoken across about the toolkit to other jurisdictions? Have you ever had that opportunity?
Not recently. Once the toolkit dates back to 2014, and we've reviewed it and we're reviewing it again because we continually need to keep looking at it. So when it came out in 2014, I would have done a bit around specialist section work and housing, where we would present it at conferences and stuff, but nothing recently. Nothing recently. Right. No, not sure whether that's a good or a bad thing.
And can I just say, Shane, on what you're saying there about not being sore on ourselves, like I do always say this whenever we do training here in Northern Ireland or even in Ireland, that we do have some of like the most knowledgeable, compassionate OTs. Yeah. Like, I would travel a lot now with this job, whether it's the UK, Europe, America, and like, we are blessed here. Like, we do have some excellent OTs. We have probably one of the best community services that I have come across in terms of not just the funding model, but the access to equipment for the people in community, whether it's seating, like even just providing seating in nursing homes, like simple things like that we take for granted. The modular ramp process, the grant process for adaptations, like, you know, we do offer a really high standard of care here in Northern Ireland, and you know, we shouldn't take that for granted, because it is not like that everywhere else. No.
When you look to England, for instance, you know, we have an integrated health and social care system here that I know they aspire to. So OTs in England, community OTs I'm talking about, would be employed by local authorities, by councils, and so they're not as integrated with health as we are here, but they do work closer to their housing colleagues. So we have a lot. Our model, I think, by and large, works well. I think the big challenges we have now are financial, and we are in very financial challenging times, which again goes back to why I think we need to reset. Yeah. And we need to think about, well, there's no more new money coming that we can see, so we need to look at how we can best manage the resources that we have, and how do we cut our cloth to suit, if you like. And that's where I think we need to lose and stop sweating the small stuff. That's when I say that.
And be more lean.
And be much more lean. Absolutely. I will use that terminology. I like that lean made simple approach that you have here in your organisation. And as I say, I think there would be learnings beyond these walls. Yeah. But you're doing that as it is.
It's very hard. Like, we went away, we talked about OT, then we talked about the Gaelic, and now we're back talking about OT. So I'm going to take you away from it again. Good. Because you mentioned earlier when we were chatting that you're involved with a men's group in, is it County Antrim or is it in Dunloy?
It's in local?
Dunloy. It's in Dunloy.
It's in Dunloy.
And it's around mental health.
Yeah.
Well, that's such a really important topic these days. Could you tell us more about that, if you don't mind?
Well, I can tell you about it, but I would immediately put in there that I'm a very, very small player in it. Because they just bring me in to do interviews with people, basically. To talk. Well, to do interviews with people. You know, they've run it's led by a guy, Bobby Carlin, who I did not know his wife worked here.
Right.
And my niece, Lauren, would also be very involved in it. But they do an awful lot of really, really good work in terms of mental health.
For men.
Dunloy Stronger. No, it's not just for men.
Just for men.
Dunloy Stronger Together, it's called, but it's they're running a men's event, which is why it came up in conversation. So they did it for the first time last year. They did a men's event which focused in on gambling addiction, and was really well received. 300 odd men there, where I interviewed Oisin McConville of Armagh GA fame and Keith Gillespie, the Man United, Newcastle, Northern Ireland footballer, who talk very openly about their gambling addictions and the impact of that. And we know from the stories come back through the group that there was some very, it was hugely impactful in terms of people in the audience who probably, if they weren't suffering from the addiction themselves, certainly had family members who had. So it really gave them a real insight as to how the Keith and Oisin had managed that. But in 2 weeks' time, they're doing an event which will be very interesting with Carl Frampton as a guest. And again, I'm going to be interviewing Carl Frampton and a gentleman called Kevin O'Reilly from Thrive Community, who I had a chat with the other night. Fascinating character. But his job now is about communications and how to present yourself, and he does a lot of interview prep. So I'm interviewing a guy who teaches people how to interview. So
I think I need to talk to him.
You do? He's a fascinating character. I can give you his contact, surely. Kevin O'Reilly, you call him. He's got a really, really interesting backstory in terms of his family life, which I'll not disclose, but in terms of the challenges of his family life and the management of his family, which have really informed. So he'll talk a lot about how, we talk a lot about resilience, and we seem to think now that we have a generation that aren't terribly resilient and aren't used to dealing with knockbacks in the way that my generation might have been, where you're told, give yourself a shake and get on with it. Whereas...
Is this particularly men or
particularly
not?
Men.
Particularly men.
Particularly men. The focus of the night is men, because, well, we all know that men don't really talk about these things. We still live in a culture where, and I'm as guilty of that as anyone, where we don't talk about our feelings. We don't talk about our feelings. It's not manly to talk about your feelings. So Kevin and Carl, because Carl's been very open about his own, Carl Frampton, and he talked about that transition into retirement, where leaving boxing and the challenges that brought to him. So what we would hope coming out of the evening, and Bobby, and they've done all the work, I just rock up in the night and do the interview, will be that we'll get the message across to young men particularly that you need to talk, and it's okay to talk, and please do talk, and find someone that you can trust and be open with. And it's like those things we always say with those events, if there's even one person in the audience that gets a benefit from it, and we know from last year's event there was more than one. Good. In terms of got the impact of that. But I take no credit whatsoever for being a driving force in it. They use me, they sort of just wheel me out once a year to do the interviews. So thanks for giving us the opportunity to talk about it.
And tell Carl Frampton thanks from me, my wife, and all our friends, Shane, because we followed him around the country. We went to England to see him.
Is that right?
He is such a legend of boxing, but such an ambassador for Northern Ireland. And he honestly gave us some of the best nights of our lives.
I'll pass that on.
From Dean, tell him from Dean.
Tell him from... He has no clue who I am, by the way, Dean. He'll know me in 2 weeks' time, because I'll get to know him on the night, and when I interview him, I will pass that on. Yeah. The only live fight I was ever at was Carl Frampton fight against Kiko Martinez.
Kiko, the first one or the second one?
The first one.
The first one, yeah. The second one, he won the title. That was at... Titanic Docks.
No, it was the Odyssey one I was at. Was that the second one? Was that the first one? That was the only fight I was ever at.
The second one was at the Titanic Quarter, and it was just...
I was ringside at the Odyssey.
That was a good fight too, the first fight. Yeah.
Actually ringside, and it gave me a massive... I know we're diverging here,
well,
Martina.
These talks can go anywhere.
I was ringside for... I'll not tell you how I got ringside, but I did. And I'd never been to a boxing match in my life, but... It gave me a massive respect for boxers, because when you're up close and you hear them taking the blows and giving the blows, you just think, how on earth do you put yourself through that? So I have massive respect, and so I loved Carl Frampton ever since.
And the atmosphere he was able to generate, he really brought a lot of Northern Ireland together, and to cheer for one person. It was just phenomenal night.
So you followed him around?
We did,
You should come on the night.
We went to England to see him. He beat Scott Quigg in Manchester. They won a title, so there's a whole lot of us went over there too, and that was another amazing night.
You should come on that night, yeah.
You never know where OT takes you.
You never know.
We're talking about boxing.
Oh, no, absolutely. We're a very diverse profession, that's for sure.
So we nearly always end the podcast and we ask, can you tell us like one story that would capture, the essence of OT? Is there anything that stands out in your career about something that you really felt you made a difference? It might be a patient or it might be something else.
Yeah, I can think of a number of, and that's, my passion for housing and the benefits of housing. I can think of a number of houses that I've been in after the properties have been adapted, right? So people who were living in very inaccessible, I could tens and hundreds of people in houses that I've been in. So there's not one particular, but it's where you've seen someone coming from a place where they had a house that, one, they couldn't get in and out of safely, and two, when they were in it, they couldn't get to the rooms they needed to get to. You could see that. I've been in many houses, as will you have, Dean, where people are sleeping in a bed in their living room with a commode beside their bed because they can't get to the rooms that they need to get to. And why the passion for housing? Because when you see when you see what it was like before, and then you see the difference once you've adapted the house and you've made the doors wider, you've done the corridors, you've made the rooms bigger, you've created a shower room or whatever. The difference that makes to your life, that you see that making to their life, makes you think, well, that's why we do the job, genuinely. And that's why because it's so tangible. It's very hard to measure it, and that's the problem with health services. We're trying to measure stuff where a lot of it sometimes is just very qualitative. It's not, you can't measure it by a metric. You can only see the difference it makes to the safety, independence, and quality of life for someone. That was really what underpins the profession. So there's a few people even come into my head as we speak where I do remember going out to do that final inspection visit and thinking, that's why I do the job. And I still would get that feeling, where I coordinate, my team coordinates what's called complex case advisory panels. So where we bring cases that are a bit stuck in the system. So what we do then is we try to find, right, who needs to be in this room, the virtual room. We do it on Teams, which is made it so much easier. COVID has had some real positives because previously we'd all wanted to sit in a room to do it. So we would look at the case as it presents, what the challenge is, why is it not moving or what, and we think, well, we need such and such, we need that department, and we bring everybody into the room. And you get real benefits from that because you can see when people work together with a common cause that they can come to decisions much quicker instead of emails bouncing around. We get people in, we talk about what the challenge is, and we see, right, what can we do to move this on?
Who is there that is putting the case for the patient? Is there a service user, or
generally it'd be the OT? It could be social. It could be a social worker. Generally, it would be the occupational therapist. And the challenge could be a housing challenge, or it could be a health challenge. It could be an OT who is trying to make a decision around a child with very disruptive behaviours in terms of how can we adapt the environment to manage that. So it could be clinical or it could be technical, and then we try to bring the two together to at least have a collaborative and joined up approach to what the solution is going to look like. So I get massive satisfaction sometimes out of those. Those have really, but what they also have demonstrated is that there's a lot of complexity out there. There's a lot of people living with very, very challenging circumstances. And I think what we want to try and do is not make the system another challenge, if you know what I mean. They've enough challenges in their life without the challenges of some of the stuff that we're involved in. So we need to try and make that a wee bit less painful for people because if you're trying to manage someone, I was struck recently, I went to a conference in Birmingham and I was struck, there was a presentation from a lady who was a doctor and she went on to have a child, but the child had very, very, very complex needs. And she broke down, she actually put it onto a screen, she broke down what her day looked like. And it was actually because she showed every half hour of every day of every week she had to do something with the child, be it change, feed, peg, meet the OT, go and see the doctor. Every half hour of every day there was something going on. And she made comments that struck with me in that not all of the interactions of those people that were involved were positive, because sometimes she was made to feel as if people were there to do her a favour, right? And she said, I had a disabled child. I don't need favours. I just need solutions to the problem that I'm having. So don't make me feel as if you're doing me a favour. Yeah. And that really did struck with me. And I when I was talking to students last week, I actually used that example to say, whatever you do in your professional career, never actually make someone feel that you're doing them a favour. You're there to provide a service and you're there to support them, but don't make them feel belittled in the midst of that. Yeah. Because sometimes, and when you hear people like that who have that lived experience, I think there's massive learnings from that. So we need to be very careful we're not too focused on the system and moving people through the process, and actually take the time to listen to what their problem is and find out what can I do for you more than doing on to. You know, sometimes we can be guilty of doing on to. Yes. But in the busyness of life, sometimes that's the reality. So cases like that, complex cases, seeing solutions, I still get enormous satisfaction, even 33 years later. Yeah.
Very good.
You're some man for one man, Shane. You know that.
Jesus, Dean, I don't know about that. It's
see, out of all the change you have done, like what is it? What one change that you've been responsible for that you're most proud of?
The toolkit.
The toolkit.
The design toolkit.
Yeah.
Yeah. I think it's the biggest impact on practice. Yeah.
Which is used all over Northern Ireland.
All over the north now. Yeah.
And will that be implemented eventually across UK, maybe Ireland, or?
I think they use the space standards more. The communications are pretty unique to Northern Ireland in terms to operate. So I think they use the space standards that we've developed a lot. So we did those with disabled people, but that would be the thing that would give me the most pride, yeah. For sure, if I had to pick.
And there was a lot of work when they did that over a very long time.
Going to be followed now by the equipment review, I think. The direction it's going, I think if it goes where we think it could go, I think that would be, if I was going to say there would be a legacy in terms of what you did, it could be the potential transformation of equipment services.
Absolutely.
Yeah.
I think that would be something really.
It'll be transformative. It has the potential to be transformative. But it's still early days. We're still working it out. But the toolkit's probably it, Dean.
And there's so many parallels in what you done with the modular ramps and what actually we're trying to do now with seating within the acute environment. We need someone that has that ability to step back and say, yes, this could be an investment now, you know, and it's going to cost a lot of money now, but 5-10 years down the line, it's going to save that, you know, and it's so black and white. It's like so obvious. But people are so restricted to these 1 year budgets, and it's trying to find that person that has that bravery and foresight. They say, you know, this is what we need to do now. So there's so many when I was thinking about that story, there's a lot of parallels and exactly like what we're trying to do now at the minute with seating in the hospital setting.
No, and the problem is it's changing the health. It's like turning the oil tanker. It takes forever. It just does. It's hugely frustrating that we have. And then OT, to be fair, you know, OT's not managing itself. It's been managed by managers in the system who are not OTs. So it could be nurses, it could be podiatrists, it could be social workers, it could be whatever. So sometimes the profession doesn't even have the autonomy or the permission to make the change. Do you know what I mean? I was probably pointy enough to elbow to get in there and just say, this is the way it's going to be. But it's difficult. I don't underestimate how difficult it is for people in the field to make the change. It's not easy.
But ultimately, like you... And correct me if I'm wrong, like you presented a business case that ultimately saved the trust a lot of money and probably continues to do that.
Absolutely.
Because you can't reuse a concrete ramp, right? You know, you're...
With the biggest one in the modular ramp, we could have talked about it, and you were involved in the case, right? A friend of mine. But his father had motor neurone disease, and it was rapidly progressing. He's since passed, obviously, but... you got the seat, and we turned it around very, very quickly, and his access was very poor, and we got a modular ramp system in to get him in and out of the house. So for the last year of his life, at least he was able to get in and out of the house. But the beauty of it as well was that the family would have said was that when he passed, they weren't left with the permanent reminder of a concrete ramp structure at the front of their house. Mm-hmm. They were able to take away the ramp and return the house to its original state. Mm-hmm. So that would have been a benefit that I didn't have in the business case. Mm-hmm. No. But in terms of the impact of the provision of it on the service user, it was hugely impactful to them, in that they just, because if we put concrete ramps in, they're big, beastly structures of things that when they're no longer needed, they're a permanent reminder that someone, plus we would say now that they would even be sort of displaying the fact that there's someone with a disability in the house.
Yes.
So it almost like a red flag. But that always struck with me. That case still struck, and it was I got personally involved because it was a friend of mine's father, and I knew the father extremely well. But that's what came out of the modular ramp system more than anything else. They got in and out of the house for the last year of his life, but it wasn't left after he passed.
That's right.
Yeah. So what would have been the alternative?
The alternative at that, they owned their own house, so the alternative would have been going through the Disabled Facilities Grants process, which, as you will know, is a means-tested process, so it's dependent on your income, what you're entitled to. The alternative would have been to get the ramp provided through that process that, even with a fair wind, would have taken 6 months to a year to get the ramp in place.
He didn't have that time.
He didn't have that time.
No.
He didn't have 6 months to a year. He passed probably about 9 months after we did it. So he had 9 months getting in and out of his house. Yeah. Whereas the alternative was exactly that, as you described, through the grants process that would have taken that. And he may have ended his days never getting out of his house again. Or they would have had to have bumped him down steps, and the safety and the dignity of that for someone who's in a wheelchair, is not nice. So that case still, and I do remember your input to that case. Yeah.
Let me take you back, because we worked together. I remembered you as the manager, but I never remembered working alongside you. And that was way back 20-something years ago. Mm-hmm. And I had left the health service at the time, and I was just asked to do some private work with regard to children. Mm-hmm. And what did you say to me just earlier?
Well, I remember because you sat across the desk from each other. Do you not remember that? So I didn't make much impression, Martina. Because I remember the office we were. I couldn't remember yesterday, but I remember that. And you came in to do that work that you talked about, and I was a community OT. I had some management responsibilities, but I wasn't the manager as such. But I remember it was around that time you were moving to the business, and you were thinking of what you have. And I honestly can hand on heart say I thought you were mad. I genuinely thought, Martina's pie in the sky ideas. This will never work. She'll probably end up back with us at some point. But when I look around what you've done now, I'm actually blown away. Well, who was right and who was wrong? You took the risk.
No,
you left the system.
I think you were right. I was mad.
Well, I thought you were. I genuinely thought you were mad. And I thought, because at that point I was so, I was so thinking, oh my God, imagine leaving the protection of a job that comes with a pension and comes with good terms and conditions. Why would you do that? But obviously you had a bigger vision than some of the rest of us. So it's a credit that you've got to where it is.
Yeah. Well, I was mad doing it probably, but I wouldn't have done it had it not been for my husband, because he was never one person that said, you've got a good job, you've got a pension, stick with it. He was one that would have said, if you want to try it, give it a go. You can always do something else. Now, I did say I would never go back to working as an OT in the health service. Yeah. But I would have done something else. I don't know what I would have done. But I was a bit mad. But sure, it worked all right.
I think it's worked extremely well. But you're probably a very good example of I think I used the term earlier about free thinkers. Mm-hmm. And sometimes the bureaucratic system of health service and big organisations isn't a great place for free thinkers, because you want to do things, you want to make things happen, and you're constrained by just the system. Whereas what you did means you could make it happen and nobody could hold you. You were accountable for yourself and you could do it. So it's I always admire people that do that, because I was never brave enough to do it.
Well, you haven't the same security when you move out, because you are on your own. That's the drawback. But as you say, the upside is that you have your autonomy. You can make your own decisions. And I just feel it's a shame that people like that feel that they have to move out of the health service to do that.
Yeah.
Because then we're losing people that are creative, that are thinkers.
Yeah.
So if the health service would allow a bit of that, it would maybe move things on a bit quicker.
It would.
Yeah.
No, I think again I go back to the reset, and I think reset should be an opportunity to reflect and actually, well, why do we do it this way? Because that's the way we've always done it. Nobody's asking those questions. There's things I can see the profession doing and I'm thinking, why? Why?
But I think one of the things that we could, that let's say, for example, health and business need to come together, like the lean culture, using what we've done here and bringing that to the health service and working together rather than everybody doing their own thing. That would be something that would maybe bring it.
I would love to see that, and because you get opportunities for leadership training everywhere or every organisation would be leadership training, but I'm not sure that drills enough into, because that's about managing people, and I think there's huge scope in terms of changing practice and changing systems and looking to be a bit freer thinking in terms of how we do stuff and be a bit less fixated on the process and the system and looking at how can we work around the process, how can we move the roadblocks, how can we get over that, how can we find a way around that. So, because we still, even you'll still hear, even if you're trying to take anybody through a change, well, we can't do that. You're thinking, well, why? What's stopping us from doing it? And maybe we need to challenge ourselves a wee bit more around that sort of thing. And that doesn't happen enough.
No. And the other thing that we do here, this isn't just like words, this is the way we always have the patient at the centre of everything.
Yeah.
The patient and the caregiver, the person who's looking after that person. If you never lose sight of that, I know when I talked to Porrick, he said, when they would have these multidisciplinary, I remember asking him, I think it might be in the book, I asked him, how did you feel OT was represented? He says, it wasn't about the OT, it wasn't about the nurse, it was about keeping the patient at the centre of it. That's what Porrick said. It's never about, my ego or somebody else's ego. It's bring it right back. This is for the patient, this is for the caregiver, the family or whoever. And I think if the health service did that cultural change would make, because we do get tied up in other things. Something we do here at Seating Matters, and it's not just words, we keep the patient and the family and the care staff at the centre of everything we do. Every decision we make is, how is this going to impact the patient? How is this going to impact the care staff? We keep them very much at the centre of everything. Our design process, or everything, our ordering, everything is about the patient. And I think if the health service did that, I think if they just, because when I was speaking to Porrick, he said, I was asking him, when you're around the table with all these disciplines, how do you feel occupational therapy is represented? And he says, but it's not about the OT. Yeah. He says, it's about the patient. He says, every time we were at a meeting and someone had a discussion about their role, he would say, I just took it back and I says, put the patient at the centre of it.
Yeah. And we would say that we do, in terms of being patient-centred. It's interesting because I do a wee bit on the undergraduate programme for OTs. And what I actually said to OTs, said to the students or second-year students, is that when you go in to do an assessment in someone's home, the privacy of someone's home, just never forget that you have been invited into their home. The first question you should ask is, what can I do for you? That should be your first question. Not, I'm the OT and I'm here to do this for you. It's, what can I do for you? And we sometimes then get to the point of where we're trying to say no to things, right? Or we're looking at criteria that doesn't meet the criteria, therefore you cannot get. But the other question I would always ask was, well, if we don't, what's the alternative? So if we don't provide it, what's the alternative? What impact is that going to have on that person's life as a consequence of not meeting the criteria? I hate the word criteria, by the way. Yeah. It should be guidance, and then we interpret the guidance through our clinical judgment, as opposed to saying, well, you don't meet the criteria, therefore you do not get. So we start to think about, well, what's the alternative of not doing something? So we try to find ways to say yes, as opposed to trying to find ways of saying no, which sometimes happens in the health service, and in terms of how we operate.
I like that. Try to find ways to say yes instead of ways to say no. But
it's just a shift of...
It's a shift of culture in some ways. That's not to mean to say it's an open door and people get everything they want. I think there has to be an assessment process, and any judgment that we make as professionals needs to be based on clinical need. So there has to be a clinical need. It can't be someone wanting something just because they want it. But we need to be less focused on trying to not let someone get something, as opposed to finding a way to make it work for them. Yeah.
It's absolutely amazing, the work that you're doing, and keep doing it, Shane, because we need people like you to stay in the system and not leave the system like I did. Stay in, although we are doing our part in trying to change things and, move things along as well on the outside. But you need people to stay in the system as well and keep, as you say, beating that drum. Yeah. So thank you so much. And thank you, Dean, for joining us today.
Thank you very much,
Did you enjoy your chat with Shane?
I did indeed. I feel very privileged to be on this podcast with two really inspiring occupational therapists. So thank you.
Thank you very much.
Thank you for peer pressuring me into it.
Well, look, thank you. It's a pleasure, actually. It's been so good to see Dean again, because I was honestly an honorary occupational therapist.
Yeah, I think he should get.
If there's such a thing, there must be a nomination process for that. And thank you, Martina. Yeah. I've been I'm flabbergasted. Did you watch Celebrity Traders? No. Did anybody watch Celebrity Traders? Kate Garraway was in it, and that she used the word flabbergasted, and everybody laughed. Who says that word? But I have been flabbergasted by your setup here. I think there's an awful lot of learning that could be applied elsewhere. Yeah. So thanks for having us.
Not at all. It's a pleasure. And thank you.
Thank you.